Hello, my name is Mike McDonald. I'm a cardiologist in the Division of Cardiology at the University Health Network in Mount Sinai Hospital. And this is the first in a two-part series of lectures on heart failure. And this first part is going to focus on the pathophysiology, particularly with what we refer to as chronic heart failure. These are my disclosures. And some learning objectives to frame things. At the end of the week, we hope that you're able to define heart failure, ventricular remodeling, systolic dysfunction, and diastolic dysfunction. Describe the neurohumoral or neurohormonal changes in heart failure, and be able to list the common causes of heart failure. And by the end of this particular module, we want you to be able to define heart failure as a pathologic syndrome and to list some of the common causes of heart failure, describe the pathophysiology of the heart failure state, including myocardial injury and remodeling, concentric versus eccentric remodeling, systolic and diastolic dysfunction. I hope to clarify those terms. So to start out, what is heart failure? If you read most textbook definitions or guideline-based definitions, it's something cumbersome like this. Heart failure is a complex syndrome in which abnormal heart function results in or increases the risk of clinical symptoms and signs of low cardiac output and/or pulmonary or systemic congestion. And when you distill it down to its core elements, heart failure is really referring to the heart as a pump, which is either too weak, and we call that systolic dysfunction, or too stiff, more commonly known as diastolic dysfunction, to maintain circulation without running the risk of congestion. So the heart is too weak or too stiff to maintain effective circulation. So what are the causes of heart failure? And you'll see this framed slightly differently in the second part of this talk. But essentially, heart failure can result from any form of heart disease. It's the final common pathway or the end point of all heart disease and all heart conditions. And it's helpful to think of things anatomically. So if we think of the coronary arteries, the most common cause of heart failure in North America, for example, would be coronary artery disease or myocardial infarct. It leaves the heart scarred, damaged, and susceptible to failing. There's heart muscle disease, we call those cardiomyopathies, and then there's diseases of the endocardium or valves, there's diseases of the lining of the heart or the pericardium, and there's systemic illness and disease that can lead to heart failure over time. This is an example of a heart that's been damaged following a heart attack, and you can see on the panel on the left is the histology of somebody who's suffered an acute myocardial infarction. There's a lot of inflammatory debris and fibrinous debris invading the healthy myocytes. And on the right side of the screen is an anatomy or pathology specimen, the short axis of the heart, where you can see that the whole anterior wall has been replaced by scar tissue rather than the healthy myocardium that you see in the inferior wall or the bottom half of your screen on the right. And it's not hard to imagine that this would lead to an ineffective pump. It's not able to do its job because half the heart muscle, in fact, has died. And when we think of the scheme or the pathophysiology scheme of how a person gets from a healthy heart to a diseased heart to developing franco-overt heart failure, this is one way to conceptualize things. If you start with a normal heart function, some kind of injury occurs. That might be an infection or more commonly ischemia or infarction, and you get some early myocardial dysfunction. And then we get this process of hormonal, or sometimes referred to as neurohumoral activation, and we'll talk a little bit more about that because that is an essential point. And you end up with a state usually of persistent myocardial dysfunction. Sometimes that insult or injury is transient and you revert to normal heart function, but that's the exception and not the rule. As a rule, the heart does not regenerate and replenish itself. Once you have damaged or diseased or dead heart muscle tissue, it persists. And then over time, the heart can exist in this compensated phase where it doesn't work perfectly normally, but a patient wouldn't notice any symptoms because it has adapted. And then what happens over time, for reasons that are sometimes unclear, people develop frank symptoms of the heart failure state. And then unfortunately, the disease progresses inexorably towards refractory heart failure, death, or transplantation. And we, of course, use devices, medications, sometimes surgery to try and restore the heart function in the patient from a decompensated phase to a compensated phase. We can also think of this, and this is a useful construct, of the spectrum of heart failure according to disease stages. So stage A would be patients, for example, who have risk factors for heart disease, cigarette smoking, diabetes, hypertension, dyslipidemia, for example, obesity. Stage B is when somebody's had an injury to their heart. They've had their heart attack, but they're compensated. And then stage C is really the onset of symptoms of the heart failure syndrome. and patients can live in stage C with some moderate or even severe disability, and unfortunately they will progress to what's known as end-stage or advanced heart failure, stage D heart failure, and these are patients with a very high mortality and a very poor prognosis. And if we think of things pathophysiologically, this slide should be a review. This is a famous physiology relationship known as the Frank-Starling curve. And this describes the relationship between filling in the ventricle at the end of diastole, the filling phase of the cardiac cycle, and cardiac output or stroke volume. So you can increase the end diastolic volume in the ventricle, the left ventricle for example, to a point beyond which there's no further increment or gain in cardiac output or stroke volume. So what does a failing heart look like? Well, it follows the same relationship, but the curve is downshifted. And if you think of severe dysfunction, just to maintain a borderline stroke volume and cardiac output, the pressure has to ride pretty high in terms of end diastolic filling or end diastolic pressure. And this is the main driver or contributor of symptoms. I referred to the compensated state and the decompensated state earlier. And this is one graphic representation or physiologic representation of what that might look like. As in the severely dysfunctional heart, as you increase diastolic filling in order to maintain stroke volume at an acceptable rate or acceptable amount, further increases in end diastolic pressure put the patient at risk of decompensating, and we call that pulmonary edema. That is the left-sided heart manifestation of frank failure. In other words, the pressure rises in the left ventricle so high without much further augmentation of stroke volume, and that rise in pressure is transmitted backwards through the circulation into the lungs. And the patient actually experiences symptoms related to that pressure, and we call that pulmonary edema. And I'll have an example of that later on. This is a schematic of the circulatory system. And again, if you look at the cartoon or the schematic, the left ventricle connected to the left atrium, of course, that's where the problem is in left-sided heart failure. The pressures in the left ventricle rise, as per the Frank-Starling, to maintain cardiac output. Pressures in the left atrium rise secondarily, and that back pressure is transmitted through the pulmonary veins and pulmonary capillaries into the lungs to which they're attached. And as that hydrostatic pressure rises, that fluid can actually leak out of the vessels into the lungs, and the patient experiences pulmonary edema. And that's one of the manifestations and devastating symptoms of congestive heart failure or heart failure. What else happens pathophysiologically when the heart begins to fail? Well, as the heart fails and stroke volume is impaired or cardiac output is impaired, the blood pressure will fall, and the body has a number of homeostatic mechanisms built in to try and compensate for that. The first thing that happens in time is the activation of the sympathetic nervous system. And the sympathetic nervous system products are essentially epinephrine and norepinephrine. They cause a lot of increased contractility of the heart, peripheral vasoconstriction or squeezing of the blood vessels to maintain cardiac output, and then they cause the kidney to retain more salt and water. Over time, days, days, and weeks later, you get activation of the renin-angiotensin-aldosterone system. That's a very potent neurohormonal upregulation mechanism that augments heart rate and contractility, vasoconstriction, and decreases renal excretion of salt and water. In other words, you retain more circulating volume as a protective mechanism to low blood pressure. And then finally, in patients who have severe or extreme neurohormonal activation, you get release of antidiuretic hormone, ADH, also known as vasopressin. And all of these mechanisms come into play to try and restore circulating volume and preload to maintain patients on that extreme end of the Frank-Starling curve. And this is an important concept. I mentioned remodeling in the pathophysiologic scheme earlier, but what remodeling specifically is anatomic changes in the ventricle that are initially adaptive to hemodynamic stress following injury. So they're anatomic changes, and neurohormonal is the key underlying mechanism. So as those neurohormonal axes get upregulated, you get a remodeled, anatomically changed ventricle to try and compensate. Unfortunately, over time, that altered geometry in cell biology becomes maladaptive, and it's mechanically disadvantageous, and I'll show you an example of what that looks like. For example, remodeling can result in eccentric hypertrophy of the left ventricle. If you think of the heart in cross-section as a nice normal circular or spherical organ, over time with upregulation of the neurohormones, it eccentrically enlarges. And in conditions where the volume of the heart is excessive, typically when the heart is too weak or in systolic dysfunction, with upregulation of the renin-angiotensin-aldosterone axis, the sympathetic nervous system, the heart actually enlarges. You can accommodate more end-diastolic volume, which is adaptive, but you can see from the shape change in the heart, this may have some mechanical disadvantage. For a given ejection fraction, or the amount of blood ejected as a function of what you start with in end diastole, there's a greater stroke volume with eccentric hypertrophy. And so that's part of the adaptation, but unfortunately, as indicated, this is later maladaptive. Here's an example of a dilated heart. We call this dilated cardiomyopathy. It could be from a number of causes, but you can see that the heart is big, eccentric, and floppy looking, and does not have the normal spherical shape and mechanical advantages. Remodeling can also result in what we call concentric hypertrophy, again referring to the normal size and shape of a spherical heart or circular heart in cross-section. And when you look at concentric hypertrophy, this is where the myocytes actually thicken in parallel. And they do this as an adaptation to excess loading on the heart. So as the afterload, for example, rises, the heart walls actually thicken to minimize wall tension. And this can be adaptive because it's good to minimize wall tension, has more favorable myocardial energetics. Unfortunately, a big, stiff, concentrically hypertrophied heart has mechanical disadvantages, particularly as it relates to diastolic filling. The heart is stiff, doesn't relax as well, and can lead to diastolic dysfunction. Here's an example. In patients with chronic hypertension, that load imposed, or the afterload imposed by hypertension, will result in concentric hypertrophy, and that results in hypertensive cardiomyopathy. There's less wall tension, but it doesn't take a lot of imagination to see why this could be mechanically disadvantageous, hemodynamically disadvantageous. That cavity in the heart is much smaller, the heart is stiffer, it doesn't relax as well in diastole, can't fill as well, so the pressures have to rise in order to compensate and fill the ventricle adequately to maintain cardiac output. Here's an example of a primary inherited cardiomyopathy known as hypertrophic cardiomyopathy. This would be an extreme example. Again, the myocytes are concentrically hypertrophied, so you can see that this heart is not going to function as well mechanically as a normal-sized heart. So neurohormonal activation is really the central mechanism of progressive heart failure. Again, going back to the myocardial insult and the initial left ventricular dysfunction, put another way, as neurohormonal activation gets upregulated, you get this progressive remodeling, concentric remodeling, eccentric remodeling, and that begets more left ventricular dysfunction. As the left ventricle becomes then more dysfunctional, you get more neurohormonal activation. So you can see the vicious cycle that is perpetuated. And we take advantage of this in terms of our medical therapy. Most of our medications, you'll hear about shortly, are really aimed at interrupting this cycle, particularly counteracting the neurohormonal upregulation process. So in summary, following injury, the heart can compensate and maintain adequate circulation, but this occurs at the expense of remodeling, unfavorable geometric changes, and as a result of increased circulating catecholamines, that's norepinephrine, epinephrine, and angiotensin II, and other byproducts of neurohormonal upregulation. I mentioned this concept of systolic dysfunction, the heart is too weak to maintain circulation, and diastolic dysfunction, the heart is too stiff to maintain adequate circulation. If we think of the heart as a half sphere or teacup model, as I like to call it, we can see that in patients with systolic heart failure, where the main problem is the heart is too weak, it's not contracting very well, these patients typically have hearts that are characterized by a low ejection fraction, the left ventricle is dilated and eccentrically hypertrophied, the wall thickness may be normal. On the other side of the equation, some patients have transitioned from a normal left ventricle to one with diastolic dysfunction and impaired left ventricular filling. In other words, the heart may be squeezing well enough, but it's not filling in diastole very well. These patients typically have preserved systolic function, a normal left ventricular size, but the walls of the heart are thick with concentric hypertrophy. And to add even more confusion into life and into the mix. Sometimes these conditions can coexist. You can have stressors on the heart that cause eccentric hypertrophy at the same time as concentric hypertrophy, and you can get elements of both systolic dysfunction and diastolic dysfunction. And I put this up for information purposes. This can sometimes confuse students and sometimes clarify things for students, but really, this describes a relationship between the left ventricular pressure and left ventricular volume. If you look at the normal curve in black compared to a patient with systolic dysfunction in red, you can see that the overall stroke volume, or cardiac output, which is represented by the area under the curve, is less in systolic dysfunction. At end diastole, the volume in the ventricle is higher because of the eccentric enlargement, but the impaired contractility results in a dramatic reduction in forward stroke volume. So the overall effect, despite the higher volumes, is a reduction in stroke volume and cardiac output. In patients with diastolic dysfunction, again, you see the diastolic dysfunction curve in purple inscribed within the systolic dysfunction. The pressures generated are similar in systole, and everything operates in higher end diastolic pressures. So for a given end diastolic volume in diastole, the pressures are necessarily higher. There is an obligatory rise in end diastolic pressures to maintain adequate preload to maintain cardiac output. So overall, the problem here isn't the force of the ventricle able to generate sufficient stroke volume. The problem is the loading of the ventricle at the end of diastole. So the pressures are higher, the volumes are lower, and the total stroke volume or cardiac output remains low. So to review, you should now be able to define heart failure as a pathologic syndrome. You should be able to list some common causes of heart failure and describe the pathophysiology of the heart failure state, including myocardial injury and remodeling, concentric versus eccentric remodeling, systolic and diastolic dysfunction. Thank you very much.